Maya, you can start.
So good evening, everyone, and welcome to today's webinar on the multidisciplinary management of migraine. So as you all know, migraine is a complex neurological disorder that affects millions of individuals worldwide, and it's often a significant cause of disability, and it impacts negatively the quality of life of our patients. And due to its multifaceted nature, effective management requires collaboration across various healthcare disciplines. And that's the aim of this series of the 360 holistic management approach for migraine. And in this session today, we will aim to provide a comprehensive overview of strategies for managing migraine to improve patient care and foster a collaborative model of treatment. First, before introducing our moderator of the session today, who will lead this webinar, and our first speaker, Dr. Muhammad Harib, please allow me to thank our sponsor for tonight, Lundbeck, for supporting this exceptional educational activity. So thank you, Lundbeck, for supporting us. And without no further ado, let me introduce Dr. Muhammad Harib, our moderator again and first speaker. So Dr. Harib completed his neurological residency and epilepsy fellowship with clinical neurophysiology at the American University in Beirut in 2007. He obtained his residency in internal medicine from the American University of Beirut in 2002, and he also obtained his medical degree from the Lebanese University in 1999. Dr. Harib was a consultant neurologist in the ICPN American Center of Psychiatry and Neurology in Abu Dhabi, and he is currently a consultant neurologist at Harley Street Medical Center as well in Abu Dhabi. And he has more than 15 years of experience in managing neurological disease, among us migraine as well. He has a deep experience with adult epilepsy. Also, Dr. Harib works with adults with headache, migraine, Alzheimer's disease, cognitive impairment, multiple sclerosis, peripheral neuropathy, radiculopathy, Parkinson's disease, cerebrovascular accident, depression, and anxiety, in addition to Botox injection for migraine headache. So please join me in welcoming Dr. Harib, who will give us the first presentation. Dr. Harib, it's an honor to have you with us. Please start your presentation. The floor is yours.
Thank you, dear Maya, for this nice introduction. And it is my pleasure. Thank you, dear Maya, for this nice introduction. It is always my pleasure to present my lecture and also to moderate these sessions. Okay, my lecture will be migraine guidelines across continent, across American Headache Society, European Headache Federation, and AUE consensus.
Dr. Harb, can you please share the slides?
Okay. ظهرت؟
Still not yet. You just need to press on the share button.
ما عم تطلع ليش؟ لحظة شوي. Stop.
So while Dr. Harib is sharing his presentation, I would like to remind our attendees that this webinar is CME accredited and that you will obtain your certificate of attendance within 1 week of today. You will receive it by email.
ظهرت؟
So now, now your slides are showing.
Okay. Okay, thank you again, Maya, for this nice introduction, and sorry for this technical problem. My lecture would be, I will present about migraine guidelines across continent, American Headache Society, European Headache Federation, and about UEE consensus. As usual, these are my disclosures. On daily basis, as a neurologist, I am seeing patients coming to my clinic having headache attacks. For every patient coming to a neurologist having a headache attacks, a neurologist have two initial steps. First of all, a neurologist should take a detailed medical history because, as you know, we have two big entities concerning headache. We have primary headache and we have secondary headache. Primary headache, we are talking about migraine headache, tension headache, and even cluster headache. Concerning secondary headaches, we have hypertension, subarachnoid hemorrhage, brain tumor, primary brain tumor, or brain metastasis, and even we have encephalitis or meningitis and extra. For this, for every patient coming with headache, we have to search for the characteristic of this headache. Let's see migraine. Migraine, it is a chronic headache. It is intermittent. It is throbbing. Each attack lasts between 4 hours to 3 days. It is affecting the quality of life of our patient and associated with other symptoms like nausea and or vomiting, phonophobia and or photophobia. In addition to this characteristic, a neurologist should perform a detailed neurological exam because patients having primary headaches, usually their physical exam is completely normal. In addition to the medical history and to the physical exam, we have to search, is there any familial history? Because 50% of patients having migraine usually having a positive family history. If we back to the history, the word migraine came from the Greek hemicrania, which means pain on one side of the head. Concerning the prevalence of headache in the population, globally, more than 10% of population will suffer from migraine. If we took America, about 9.7%, Central and South Africa, 16.4%, and Europe, 11.4%, Africa, 10.4%, Asia and Australia, about 10.1%. Usually, migraine headache affect the female population. It is more frequent in female versus male. If we take the prevalence of migraine versus the traditional medical condition like asthma, osteoarthritis, and diabetes, migraine will come in the first rank. Even if we compare the migraine prevalence versus the traditional neurological disorders like Alzheimer's disease, epilepsy, multiple sclerosis, and Huntington disease, always migraine will come in the first row. This high prevalence certainly have a negative impact on the population. Migraine will lead definitely will be a leading cause of disability and will result in significant economical impact. They reduce our loss of production and healthcare cost. Even patient having migraine will have certainly and sometimes anxiety, depression, nausea, and photophobia and phonophobia. Now, the $1 million question. How to manage a patient coming for migraine? For every patient coming with headache, we have to tailor a specific plan for him. As I said in the beginning, a neurologist should take a detailed medical history, perform a good physical exam. In some cases, if we need to perform some investigation, we can do it. And finally, we can label the patient with definitive diagnosis. if our patient is having episodic migraine headache or patient having chronic migraine headache. After labeling the patient with specific diagnosis, we have to tailor for him a specific treatment plan. We have to see if our patient is eligible only for acute treatment or he is also eligible for preventive treatment. Concerning the abortive treatment or acute treatment, it is you only use during the attacks. The main goal to prescribe this kind of medication is to abort a headache attacks. We have plenty of variety. We have analgesics, triptan, antiemetic, ergos, and some combinations. Now, for patient having recurrent migraine attacks, or in other words, having more than 3 to 4 attacks per month, patient is abusing acute treatment, and patient having disability with migraine attacks, this patient is eligible for preventive treatment. Until 2018, we have plenty of variety concerning preventive treatment. We have beta blockers, we have calcium channels blockers, anti-seizure drugs, antidepressant, and even ARB. Concerning chronic migraine headache, we can use beta blocker, anti-seizure drug, and calcium channel blocker, but we have also to use Botox injection for chronic migraine headache. Now, what are the recent guidelines concerning the management of patient having migraine headaches, concerning acute treatment and concerning preventive treatment? The main goal of presenting this presentation is to compare migraine management guideline across continent, talking about American Headache Society, European Headache Federation, and UE. The highlights regional difference in management strategy and to demonstrate the importance of understanding this variation. The American Headache Society focus in North America. The European Headache Federation targets European count of population, and AUE consensus represent Gulf regional approach. All these guidelines follow the international chronic headache, international classification of headache disorder 3 criteria. Let's start first with the American Headache Society. The American Headache Society is the leading authority on headache and migraine management in North America. As we know, it's provide evidence-based recommendation for diagnosis and treatment, and always the guidelines are regularly updated based on new research. What are the guidelines, American Headache Society guidelines concerning acute? For every patient, to label a patient with migraine headache, they use the International Classification of Headache Disorders 3. For this, every patient having recurrent headache, each attack lasts between 4 hours to 72 hours. It is unilateral headache, pulsating. It is moderate to severe, worse by physical activity, and are associated with nausea and or vomiting, phonophobia, and photophobia. In this case, we can label this patient with migraine headache. For the acute or abortive treatment, the first-line medication include NSAID and triptans. Combination, we can use combination like triptans and naproxen are also recommended, but opioid I generally avoided. Why? Because I because we have very high risk of medication overuse headache. In addition to pharmacological approach, we have non-pharmacological approach like relaxation technique and proper hydration. What are the latest guidelines concerning acute treatment for migraine headache in American Headache Society? If the patient having mild to moderate, we can use NSAID, non-opioid analgesics, or acetaminophen or caffeinated analgesic combinations. In case of having moderate to severe, in this case, we have many options. We have triptans, we have gepants, and ditan. But if the patient is having contraindication or inability to tolerate triptans or adequate response to one or to two more triptan, in this case, it's much better to start on gpan or ditans. And these recommendations are for patients having more than 18 years old of age. Concerning preventive treatment, every patient having frequent migraine attacks more than 4 days per month, poor responder to acute treatment, or we are afraid to have abusing acute treatment. In this case, we have very concerned to having medication overuse headache, or the migraine attacks having this causing disability for our patient. These are the main indication for starting preventive treatment for patient having migraine attacks. In this case, we have, as I said in the beginning, beta blockers, calcium channels blocker, anti-seizure drug, ARB, and recently GCRP inhibitors. In addition, for patient having migraine attack, we have two lifestyle changes like sleep hygiene, exercise, dietary modifications. Now, what are the latest recommendation or guidelines for prevention of migraine headaches attacks? The new guidelines encourage the clinician to consider GCRP targeting therapy as a first-line approach for migraine prevention along with previous first-line treatment, without requirement for prior failure to other classes of migraine preventive treatment. In the past, is a patient coming with migraine headaches and is eligible for preventive treatment. Usually in the past, we start with a traditional preventive treatment, beta blocker, anti-seizure drug, ARB. In case of partial response or in case of failure, we shift the patient from the traditional preventive treatment to the new preventive treatment. But now, even if the patient is coming, is a naive patient, is eligible for preventive treatment, we can start this patient with a new modality of treatment with anti-GCRP. Taking in consideration special populations concerning the pediatrics, until now GCRP is not recommended because it's not got far from the FDA approval, but we have an ongoing trial concerning this issue. Concerning the abortive treatment, we can adjust dosing, first-line use of ibuprofen. Concerning the pregnancy, even now the MAPS or anti-GCRP is not indicated for pregnancy or during breastfeeding, but we have an ongoing trial concerning this issue. And concerning the abortive treatment, we have to avoid use of NSAID and triptan in later stages, and in this case, much better to use the simple analgesics. Concerning neuromodulation devices for refractory cases is indicated. Now, we go now for Europe. European Headache Federations focus on European populations and emphasize on personalized and multidisciplinary care. As usual, we have non-pharmacological and pharmacological approach concerning management of patient having recurrent migraine attacks. A holistic approach is encouraged, targeting both migraine and associated comorbid conditions like anxiety and depression. Also, European Headache Federation follows the international classification of headache disorders, unilateral throbbing, affecting quality of life, nausea, vomiting, phonophobia, and photophobia. Concerning the guidelines of European Headache Federation, it emphasizes of use of headache diary for tracking frequency, triggers, and treatment responses. Early diagnosis is encouraged to prevent the progression from episodic to chronic and even to medication overuse headache. Concerning acute treatment, it is first-line treatment like similar to American Headache Society. We can start using NSAID, triptan, or combinations. Fast-acting option, we have nasal spray like zolmatriptan, and also in the European Headache Federation, they use the anti-nausea medication such metoclopramide are often used alongside with acute treatment. Concerning non-pharmacological, we have also relaxation technique, CBT, and acupuncture. Concerning the preventive treatment, also the same indications, patient having more than 3 to 4 attacks and patient having disability or patient having abusing acute treatment. In this case, this patient is eligible for preventive treatment. Concerning the pharmacological, we have anti-seizure drug, beta blocker, and GCRP inhibitor. And non-pharmacological, we have biofeedback and stress management. Concerning the European Headache Federation, they emphasize on personalized treatment plan based on patient history and comorbidity. Now, what are the latest guidelines concerning preventive treatment for patients having recurrent migraine attacks? It's published in September 2022 concerning the use of monoclonal antibody targeting the calcitonin gene-related peptide pathway for migraine prevention. The recommendation, even a naive patient coming with migraine attacks and he eligible for preventive treatment, we can start at the beginning with monoclonal antibody. And all these studies showed that this kind of medication are very effective in sustained efficacy and also safe and long term. What about the European Headache Guidelines concerning comorbidities? The European place a strong emphasis on managing comorbidity like depression, anxiety, in addition to migraine treatment. In this case, we can use the antidepressants such as SSRI or SNRI can use for this kind of patient. Sorry. And we have the collaboration between neurologists, psychiatrists, and even psychologists concerning these patients. Now, what about the EUE guidelines concerning acute and preventive treatment? The EUE consensus on migraine management was developed to address specific healthcare challenge in Gulf region. It aims to standardize migraine management across the EUE to improve access to care, and cultural factors and genetic predisposition are considered in diagnosis and treatment. Concerning the EUE diagnostic criteria, they follow the international classification of headache disorders diagnostic criteria, but consider local environment factors like heat and dehydration as a trigger factor. Familial history is common and very important in Gulf population and taken into account in diagnosis. Early intervention emphasized to prevent progression to chronic migraine. Now, what are the EUE acute treatment recommendation? There is nice paper published in Neurology Therapeutics by Dr. Abu Bakr Madani, Dr. Sahel Rukin, and even Dr. Najir Yashi. It is similar to American Headache Society and European Headache Federation. For the first-time treatment, they include NSAID and triptans. Concerning the availability of medication is a key consideration with regional preference for certain drugs. Traditional remedies are sometimes used like hojama alongside modern pharmacological treatment. Concerning EUE preventive treatment, preventive medication, we have beta blockers, anti-seizure drug, and GCRP inhibitor are used in EUE similar to the American Headache Society and European Headache Federation guidelines. Hydration and lifestyle modification are strongly emphasized due to the local climate. Stress management and dietary intervention also important for prevention strategy. Also, a nice guideline published by Dr. Abu Bakr and Dr. Suhail and even by Dr. Najir Yashi concerning the prevention of in line with the update consensus statement of European Headache Federation. The UE consensus statement similarly recommends the use of monoclonal antibody targeting the pathway for all individuals suffering from migraine. Naive patient coming with headache and diagnosed with episodic or chronic migraine headache, with this patient, we can start anti-GCRP without any concern. What is the future concerning migraine management for acute treatment or for preventive treatment? Certainly, it is related to AI. Maybe in the future, the coming years, we have a personalized medicine. Every patient will have a special medicine. We have to tailor treatment based on genetic and clinical profiles. And maybe the future of migraine management, maybe in the next 2 to 5 years, is likely to involve a more personalized approach, integrating data from wearable devices and AI. By this slide, I came to my final slide concerning my lecture. And from now, I have to introduce Dr. Namarik. She will talk about the second topic. Dr. Namarik she is a consultant neurologist, MS specialist. She is a director and head of MS clinic in Mubarak Al Kabir Hospital. She is a clinical tutor for medical students in Faculty of Medicine, Kuwait University, and in Mubarak Hospital. She is member of Kuwait Neurological Society, also of Kuwait League Against Epilepsy, and member of American Academy of Neurology. She is clinical tutor for a Kuwait program resident under the umbrella of Kuwait Institute for Medical Specialization. Dr. Namarik, the floor is yours, and thank you.
Thank you, Dr. Harb, and good evening, everyone. So I'll just wait for the slides to be shared. So good evening, everyone. Today I'll be speaking about the vicious cycle of worsening migraine, which means the transitioning of the migraine from episodic to high-frequency episodic migraine and then to chronic migraine. Next, please. Next. So migraine, it's more than just a headache. As we know, there are phases before the patient gets the attack of the migraine. And the first phase, what we call it, is the prodromal phase. It is a phase precedes the headache attack by hours or even days. It is characterized basically by change in the mood. The patient may have depression before the attack, change in a sleep pattern. They may have insomnia. Change in the appetite. He might have a hunger, yawning, then followed by the attack of headache. Can you please press the slides? So this is the prodromal phase, it precedes the headache, and then we have the headache phase. And the headache, about 25 to 30% of the patients, they may experience aura, and the aura differs whether it is a visual aura, sensory, or aura that involves the speech of the patients. The aura shall not exceed 60 minutes. It is about 5 to 60 minutes, and then followed by the headache attack, which is from 4 hours up to 72. If it exceeds 72 hours, we call it status migrainosus, and this is emergency. Even after the headache attack, there is what we called post-dromal phase. The patients may experience changes in the mood and appetite. Can you show the slides, please? And this is the last phase, which is the prodromal phase. Next, please. So what are the types of migraine? It depends basically on the number of the frequency of the attack per month. So it is divided into episodic or chronic migraine, and later I will be explaining the differences. Also, we can subdivide the migraine into with or without aura. About 25 to 30% of the patients, they experience aura. Next, please. Next. So some patients will experience a transition from episodic migraine to a chronic migraine. Let's define each one of them. Episodic migraine, where the patients, they have from 1 to 14 migraine days per month, and there is recovery between the attacks. So the patient, for example, experienced 2 days of headache per month, and there is recovery between these two attacks. And we have what we called high frequency episodic migraine. The patient experienced from 8 to 14 migraine days per month, and it affects the patients. The impairment is moderate, and there is poor recovery as shown in the graph between the attacks. And 2.5% of those of high frequency episodic migraine may transition into chronic migraine over a period of 1 year if this was not treated. Now, chronic migraine, the definition is basically the patient experience 15 or more migraine day per month, exceeding 3 months, and there is severe impairment with no time to recover between the attacks. With the treatment, we might actually be able to convert patients with a chronic migraine into a high-frequency episodic migraine, about 26% of the cases over 2 years. Now, the goal of the treatments that was previously explained by Dr. Harb, why we put the patients on the prophylactic treatment, basically we want to provide the patients a better high quality of life. And as we can see in the questionnaires, that the patients with a chronic migraine, they are associated with lower health-related quality of life, especially if migraine is associated with other medical problems such as a psychological disorder, vascular disorders, and non-headache pain. Next, please. So what are the odds ratio of commonly occurring risk factor for progression to chronic migraine in patients with episodic migraine? It's important to mention that some factors are actually modifiable, like the patients can control it. Number one, migraine frequency. The higher the attacks per month, this puts the patient at higher risk of a progression to chronic migraines with odds ratio about 20. Medication overuse, headache, if the patients continue to have different use of different acute, or let me say abortive treatment of headache, this associated with progression to chronic migraine with an odds of 19. Comorbid condition, metabolic syndrome, obesity, overweight, depression, in addition to high caffeine consumption. There's an important point to elaborate here that each person is adapted to a certain level of caffeine in the body. A sudden withdrawal or a sudden increase in that amount can trigger headache. Next. As I mentioned earlier, there are modifiable and non-modifiable, so it is important to educate the patient about the modifiable risk factors such as anxiety, physical inactivity, obesity, acute medication overuse, and high caffeine intake. And as well as mentioned also by Dr. Harb, if there is, for example, anxiety or depression, it is recommended to use SNRI or SSRI as those modifiable risk factor. What about the non-modifiable risk factor? Younger age, female is more prone to have migraine than male, low education or socioeconomic status, and head or neck injury. Next, please. So again, there are signs of progression to chronic migraine, or the patient at a higher risk of progressing the migraine attacks if they are more frequent, or if they last longer, or are severe. We all know that migraine headache compared to tension headache, that the severity is moderate to severe. So if the pain is more, this is a sign of progression. And definitely the migraine has an increasing impact on the patient's ability to carry out the daily activity. And also the use of acute medication has also increased, is less effective, as the patient using more NSAID or abortive treatments. This puts him at a higher risk of converting from episodic to chronic migraine. Next, please. So this is the vicious cycle of worsening migraine. So some people with migraine will experience sustained worsening, and this will put the patient at a higher risk of misusing the painkiller, and this will increase by itself the severity and the frequency of the migraine. And the more the patient use abortive treatment, the migraine will become eventually resistant to those abortive treatments. This will lead to a lower quality of life of the patients, a lower ability to produce and be an efficient member of the society. Next, please. So what are the consequences for the patients? Let's talk about the psychological impact, the disability that it can cause. So more frequent migraine is associated with worsening disability and health-related quality of life. As we can see the graph on the left side, patients with a chronic migraine, about 60% of them, they have a disability. And when we talk about the impact of life, 85 or about 84% of chronic migraine patients, they have impacts on their daily activity. Next, please. What about the psychological aspect? We know that migraine is a painful condition. What about the psychological elements? Definitely, migraine can be associated with anxiety and depression. So as we can see here, the graph on the left side, about 50% of the patient with chronic migraine, they have anxiety. 30% of those 50%, they have moderate to severe anxiety. Even patients with low frequency episodic migraine, about 9% of the patients, they have anxiety. Depression, when we talk about depression, even a higher percentage of patients, up to 60% of chronic migraine, they have depression. 6% of those, they have they have severe depression. Next, please. So it is important when we treat a patient with migraine not to focus only on pain management, but also to cover the psychological aspects of the disease. And when we talk about the productivity of the patient's ability to do the daily activity, definitely there is impairment. And those patients with a chronic migraine, they are more affected. About 54% of a chronic migraine, there is impairment and the productivity, and this is basically measured. The productivity impairment is calculated by combining the absenteeism and the presenteeism in working hours. This is basically based on 2016 National Health and Wellness Survey. It is basically a cross-sectional analysis of survey data from France, Germany, Italy, Spain, and United Kingdom. Next, please. So, poor control of migraine is related to interictal anxiety and potential for a medication overuse. 15% of people with migraine felt that they were rarely or never in control of their migraine. This basically let the patient feel dissatisfied. This will lead to an increased anxiety and the urge to look for a better abortive treatment. So feeling of control are largely dependent on the effectiveness of the acute therapy. And inadequate efficacy of the acute treatment will basically lead to more frequent dosing and overuse. And as I mentioned, this will lead to conversion or progression from episodic migraine to chronic migraine, and this will also be associated with anxiety and depression. Next, please. So It is important to break this vicious cycle, basically. So strong attack frequency that can lead to overuse of the medication, that can lead to overuse medication, headache, and progression from episodic to chronic migraine. Next. Education is an important part of the treatment. And also, as mentioned earlier, there are basically the pharmacological and non-pharmacological treatment of migraine. Number one, we have to educate the patient, provide migraine-related lifestyle guidelines, and includes behavioral therapy. What's the difference basically? What's the aim of acute treatment and preventive treatment? Acute treatment is directed at reversing an attack of migraine that has already started, but a preventive treatment aims to reduce the attack frequency, severity, duration, and disability. So, matching patients with the right treatment strategy is the key to the successful management of migraine, and we have to educate the patients about reasonable results of the medication. Next. Like it is like reduction of the pain, 50% of the frequency is somehow reasonable. We don't expect basically 100 unless it is a gradual and needs a follow-up plan. So there are a variety of general migraine topics that the patient has to be educated on. Information on migraine and worsening migraine, like if he take more a painkiller or abortive treatment or abuse those medications, this can lead to progressing of migraine. Correct ways to use medication, such as avoiding medication overuse, importance of headache diary. Why it is important to have a diary, basically to compare if the patient was on abortive or on prophylactic treatment, to see the efficacy of the treatment, to diagnose the patients initially whether it is a episodic or high frequency episodic migraine or chronic migraine. So it is important, the diary, for the diagnosis and also for follow-up treatment and response to treatment. As mentioned earlier, non-pharmacological treatment, lifestyle adjustment, and the pharmacological treatment and the possible side effects. So you put the patient, for example, on a medication with certain side effect, you tell them that this might cause some drowsiness. Some of the medication cannot be given, for example, in asthmatic patients. Precautions of some of the medication, we have to educate the patient. Some medication, for example, TCA, tricyclic antidepressant, can cause weight gain and initially drowsiness. And potential trigger and trigger management, that migraine can be provoked by certain foods, certain smell, weather changes. We have to educate the patient about all these aspects. Next, please. These are some protective action may help to reduce the risk of worsening migraine, optimize acute and preventive medication, avoid or reduce caffeine, or use a caffeine in an amount that suits the body. Physical activity is important, and it is proven. Studies have shown that those who exercise, this will increase the blood circulation to the brain. This is associated with a less attack of headache. Maintain healthy weight. As I mentioned earlier, comorbid condition, obesity can worsen the headache outcomes. Stress management is difficult, but it is important. Most of the patients gets recurrent headache attack if they are under stress or anxiety, and very important to emphasize on healthy sleep habits and hygiene. Next, please. So, early intervention, fast-acting preventive treatment aims to improve the health-related quality of life through prevention of disease progression. So, our aim basically is early intervention to reduce the migraine frequency, duration, and severity, prevent disease progression, and improve the quality of life of the patient in order to be a better productivity and reduce the disability. Next, please. So it is the time to break this vicious cycle. As I mentioned, there are certain aspects that benefit from breaking this cycle, improve the health quality of life, reduce the burden on the patients itself and the society, reduce the migraine and migraine severity and frequency, and reduce the acute medication use. And it is important to mention here some of the medication, they are harmful for the kidney that can lead to nephritis. Some of the medication might be harmful to the liver. Some of them led to gastritis. Recurrent use of NSAID, for example, can lead to gastritis and ulcers. So it is important to educate that and break the cycle. Next, please. So, next. So let's talk about VIPT. So it is important. So basically VIPT is one of the prophylactic treatment, which is basically an infusion every 3 months. It is a monoclonal antibody targeted toward the calcitonin gene-related peptide. It provides efficacy and fast onset of action within the first day, and also sustained efficacy. Next step, please. So, VIPT reduces both migraine frequency and severity of remaining headaches. There is fast onset of action that starts from day 1 after the infusion, with sustained efficacy over a 3 months dosing period, which is maintained over the long time. And the 3 months frequency is quite reasonable and tolerable by the patients. A lot of patients, they don't prefer to take, for example, oral medication on a daily basis. Next, please. And it is one of the important prophylactic treatment to treat chronic migraine. And by that, I end my presentation. Thank you so much.
Thank you, Dr. Namarik, for this nice and comprehensive lectures. Now we move to Dr. Tamer. Dr. Tamer is an Egyptian board certified specialist neurologist with over than 15 years of experience. He's completed his medical degree in neurology in Alexandria University, Egypt, and he is member of several community and organizations, including the American Academy of Neurology and World Stroke Organization. Through his extensive experience, Dr. Zidane can handle all neurological emergencies from stroke, multiple sclerosis care, management to epilepsy and seizure. Dr. Tamer, now he is practicing neurology in many hospitals in Dubai, like Prime and Emirates Hospital, and currently in Al Zahra Hospital, Dubai. Dr. Tamer, the floor is yours.
Thank you so, Dr. Har, for this nice introduction. I will discuss few patients who had been diagnosed with migraine and their management, and I will try to highlight on the benefit of using new molecules like eptinezumab. So as Dr. Harp say, we in the management of migraine patient, we usually focus on tailoring the medicine according to the patient needs and the profile of the patient. As Dr. Nomar also mentioned, we have acute treatment that target to stop the attack of headache, and we have the preventive treatment that target.
Dr. Tamer, can you try to share the slides, please?
So is it clear now, or?
Yes, perfect.
Yeah, that's right. So as I said that in the management of migraine, we usually tailor the medicine according to the patient needs and patient profile, following the guidelines and consensus, either American or European or local one in the UAE. So I'll present few patients and then we discuss later about their profile. First one is a 36 years old lady. She had been diagnosed with high frequency episodic migraine, and she tried 4 lines of prophylactic medications with response rate mostly between 50 to 50%. She tried beta blocker, tricyclic antidepressants, anti-CGRP, and Botox had been tried twice. She on presentation, she still have high frequency at episodic migraine attacks, around 24, 25 attacks per month. She still have menstrual migraine, even with using the prophylactic therapies. She had been started on eptinezumab 100 milligram since 2 years, and she received the last dose in August 2024. Her response rate with the medicine is around 85% of headache control, and mostly the menstrual migraine is almost nil. I will not go through details about the diagnosis and the journey of treatment, but I will highlight few points about the patient profile and the patient needs that could be matched with the use of the medicine. The second case is also 27 years female. She had been also diagnosed with high frequency episodic migraine with her aura. She is drug naive. She never tried prophylactic medication, and she visited neurology almost 2 weeks before month of Ramadan, the fasting month in Muslim, and she wished to achieve rapid control before fasting. She also started eptinezumab 100 milligram. Since that time, 2 dosage had been given with almost response rate 80% control of headache. Third case is a 29 years male. He's a cabin crew. He had been diagnosed with low frequency episodic migraine. 2 groups of prophylactic medications had been tried within a period of 3 years. Beta blocker topiramate had been tried, but the patient is non-adherent and non-compliant to the medications. Then he had been started on eptinezumab 100 milligrams since 2 years, and he is almost achieving 90% control of his headache. So as had been mentioned that we have 2 main kinds of migraine. One is the episodic, the other is chronic. It depends on the frequency of the attacks. Episodic migraine is the most common, and we have high frequency and low frequency attacks. So in the first patient profile, the patient had many attacks, around 24 migraine attacks per month with 16 migraine days per month. Her function between attacks had been disturbed, as we know that migraine will cause functional disability. It will not lead to any physical disability, but it's mainly functional disability related to presenteeism or absenteeism. And also between attacks, most of the patients, they experience a feeling of being tired, exhausted, mood swings, mood change, feeling down or depressed. So the patient mostly wants to get better through the treatment, to adjust lifestyle. She tried 4 preventive therapies with some side effects, especially with the topiramate related to the cognitive side effect, with the tricyclic antidepressant, mostly the weight gain. And also she tried one of the anti-CGRP prophylactic therapies, and we cannot say that she had been failed, but she didn't achieve accepted response rate. Maximum response was around 50-55% of reduction of the headache frequency, and most of the acute treatment was unreliable. So in such patient, we choose to start with eptinezumab as effective migraine preventive therapy that had been given as IV. The medicine is already effective to achieve a reduction of the migraine days, as well as the severity of the attacks, as we know it's a prophylactic one. And also it starts working from day 1. And also it can achieve a sustained response over, as in the studies that we'll mention, around over a period of 2 years. So here how we think about Vyapti or eptinezumab and how it matches the patient expectations. So as we highlight that mostly the medicine will work as early as possible during the first few hours from starting 1 hour. It can achieve freedom from headache pain within 4 hours after the infusion. It also had less side effects and mostly tolerable with most of the patient. And it had been proved to have a high continuity of the response rate. So for the patient, prediction of the response may simplify the life planning decision as we discussed, that the headache will affect the daily or the quality of life. Mostly it's a disabling disease related to the daily functions, and it matches the realistic treatment expectation. For us as a clinician, the medicine will help us to provide a framework for management decision. Vyapti can achieve 100% bioavailability in the blood and can achieve Cmax within 30 minutes, which confirms the efficacy from first hour, and it could be maximized within 1 day. Again, related to the efficacy, we can see that in the studies done with the Vyapti that it can work in both episodic migraine, this is study PROMISE 1, and in chronic migraine, and we can see that with a consequent dosage, it can achieve up to 41 in episodic migraine and 39% of reduction of the migraine headache. And it can start from the first dose within 1 to 4 weeks of introduction of the medicine in both episodic and chronic migraine. So this was one of the comments that I hear from patient, that she's so happy in her life and she don't think to have that migraine that affect her daily activity, and it reduce the stress she suffer from having this headache. Second thing we will highlight on the fast onset of action, as we see in the second patient, the target or the tailoring of the medicine depends on the profile, because she come like 2 weeks before month of Ramadan, and she want to achieve a better control for her headache. And as we know, most of the prophylactic medication, usually we need to assess within 1 to 3 months at least to achieve between 50 to 75 reduction of the frequency of the headache. But here we choose and discuss about the option of the Vyapti in as an option to work immediately within 1 hour and to achieve a response within 1 day. And as we see here in the study, we can see that in both episodic and chronic migraine, Vyapti or eptinezumab can achieve 50 to 52 reduction of the frequency of the attacks within 1 day, because as we said before, that it can achieve 100% of the bioavailability of the medicine in the blood. Also, one more thing, it demonstrates the efficacy within 2 hours of initiating Vyapti during migraine attack. Till now, it's not it had not been approved as acute medication, but still it's a preventive one. We can see that the patient can achieve pain freedom within 2 hours, and then this will be sustained. And there is a great difference between using Vyapti and the placebo. 23 in using Vyapti and 12 in placebo, and also absence of the most bothering symptoms in the arm of the Vyapti in the study. Also, it can achieve headache pain freedom within 4 hours, and also within 4 hours there is absence of most bothering symptom in around 65% of patients. One more thing to be highlighted, it's the rapid onset of action that as we see in the graph, we can see that eptinezumab can start working very rapid from first hour, and the effect will be consistent up to 6 hours. So we can see the rapid onset of action within 1 hour of starting the infusion, and also it's a sustained effect. This is also one comment from another patient. She was really skeptical at first, and she had lost the hope, and then finally she get the hope again. Related to the discussion of the safety issue in such medicine, we can see that in adults with chronic migraine, eptinezumab 300 milligram administered every 12 weeks up to 84 weeks, like 8 doses, as a preventive therapy. If we can see in the graph, we can see that most of the side effects was mostly manageable. The most bothering side effect was the hypersensitivity. It come after that the fatigue, and then the other side effects like constipation, back pain, dizziness. It was very, very less if we compare with other medication. And here we can see that more than 80% of patients treated with eptinezumab report clinically meaningful reduction of the MIDAS total score over 2 years. And we can see that the score had been started to improve within 12 weeks. That means within the first dose, we can achieve a good response for that. And even up to week 104, we can see the sustained response. And that's usually we discuss with the patient that even with the achievement of response 80 or 83 up to 87%, we can have sustained efficacy that will not be changed with the time. And I can see in most of our patients that they prefer to continue on the medicine even more than a year just to achieve the sustained efficacy of the medicine. So to conclude, we don't have loading dose for Vyapti. The medicine will be given over 30 minutes of IV infusion as per protocol. And we have some perspectives considering using Vyapti in UE around 3 years. Vyapti has moved from last option to primary option, but again, still the use of other prophylactic therapies is still used. But again, as Dr. Harb mentioned, and focus on tailoring the medicine. We need to select the proper patient and choose the proper medicine that match the patient needs. The ideal patients are those who want powerful, minimal adverse side effects and reliable delivery of medication. Again, Vyapti can work on both episodic and chronic migraine patient. And as we know in our clinical practice, sometimes the patient with high frequency, he moves between chronic migraine more than 15 attacks and less than 15 attacks. So in this patient, it's a little bit difficult as in first patient to choose if it's Botox will be the best response or the best option, or the anti-migraine medications with the different types that could be an option. So that again, we tailor the medicine based on the patient needs and patient profile. Also, the infusion process is less than 1 hour. There is no need for monitoring, and mostly there would be a third party of IV team that help us to achieve good delivery of the service to the patient. The treatment expectation, as we highlight, there is a fast onset of action, powerful outcome, efficacy is high, and ease of use, unless the patient had some needle phobia or he cannot tolerate the IV infusion. Some adverse effects could be there, but usually are uncommon. Most of them are related to hypersensitivity and allergic reaction. And mostly near to the infusion site, and very rare to see anaphylactic reaction against the medicine. Related to the patient satisfaction, as all of us know, most of the patient satisfaction is directed to the oral therapy. But if we provide them one IV therapy that's given less frequently, like 4 times a year, some of patients could be convinced with that unless they have a phobia, as we mentioned. There is no home injections, no need to store the medicine, no need to have all this hassle while traveling, moving from one place to another place, carrying the medicine, storing the medicine. So it's a good option. The only hassle that the patient need to go to the hospital to receive the medicine. And there is no reporting of wearing off effect. I mean, with the consequent and prolonged use of the medicine, as we see before, there is no wearing off phenomena with such medicine. Again, the medicine can achieve 100% bioavailability 4 times a year. It's an easy for some of the patients. Clinical outcome data makes a statement very powerful. Again, as we mentioned, to conclude, there is no one single medicine is the best in the market. As most of us mentioned, we need to tailor the medicine based on the patient profile, patient needs, and patient preference. Thank you so much. And thank you, Dr. Harb, and all the team for that presentation.
Thank you, Dr. Tamer, for this comprehensive lectures. Now I will open the floor for questions. The first questions for Dr. Tamer. What is the journey of chronic migraine with patient is pregnant, and what do you recommend as medication for her?
See, usually the pregnancy is a big issue in migraine. As we know, most of the patient during pregnancy, they experience less attacks. Around 85% of the patient will experience less attacks of migraine, and around 15% only they can experience worsening during pregnancy. All the anti-CGRP, there is no study that we can use during pregnancy. We have very, very limited options to use either as acute pain management or as a preventive therapy. The most safe medicine, as Dr. Harb mentioned, is acetaminophen. There are some recommendation about using Indral during certain trimester. Sometimes we try the occipital nerve block in few resistant intractable patients. Also, we can request the help of other non-pharmacological therapy like CFLE, like cognitive behavioral therapy, stress management. All of these can help us to manage migraine during pregnancy.
Okay, the next question is for me. Dr. Harb, in the era where big data and population health metrics are transforming healthcare, how do you foresee integrating real data from migraine sufferers into development of more adaptive patient-centered treatment guidelines? Very nice questions. By using real data from migraine sufferers, I think healthcare can develop more personalized and even effective treatment. Maybe by applications and wearable devices, we can track things like triggers and the treatment responses. In this case, it can allow to the doctor or the physician or maybe for the neurologist to adjust care for each patient person. This data is also, the word data help us to improve overall treatment guidelines and predict when migraine might happen and leading to better prevention and care tailored to individual needs. The next questions is for Dr. Namar. What are the cause of high level anger and aggression with migraine patients? Dr. Namarik. Oh, she's not. Dr. Tamer.
Yeah, as we know in the pathophysiology of the migraine, we know that there are many neurotransmitters. We know some of them like serotonin, B-peptide, and as we know the start of the cortical suppression waves after the vascular involvement in the trigeminal-vascular axis, this will release hundreds of neurotransmitters. Some of them are well studied and some still under many study. So one reason is related to the neuropeptides that had been released during the attack of migraine. The second thing that the migraine attack, as most of us know, there is one phase which is called the postdrome, and the postdrome is mainly most of them related to some symptoms related to fatigue, anxiety, depression. So sometimes it could last up to 48 hours after the attack. This is another explanation. I think that issue, as Dr. Namarak mentioned, there are around 45 to 50% of patients who had migraine, they have comorbid anxiety and depression.
Okay, thank you, Dr. Tamer. The next question is, what is the dose? It is 100 milligram or 200? No, like concerning Vyepti, we have two dosages. We have 100 milligram and 300 milligram. Concerning patient having episodic migraine headache, we can start with 100 milligram. But in case of patient having chronic migraine headache, in this case, it's much better to start with high dose with 300 milligram. For this reason, we have to label the patient if he is having episodic migraine headache or chronic migraine headache. In this case, in case of episodic, we can start with 100. But for patient having chronic migraine headache, it's much better not to start with 100. It is much better to start with 300 milligram. The next questions is How physical activity will lead to decrease the migraine even if it is increase the blood flow towards the brain and leads to vasodilatation, but we are using triptans in order to get vasoconstriction that will be beneficial in migraine. Dr. Tamer?
Um, I think the description of the correlation between physical activity and migraine, it's not simple as this, because as we know, migraine attacks could be worsened with the physical activity, which is the acute effect of the activity. But usually the lifestyle and sustained physical activity will improve the overall stability of the brain, especially it's not related to the blood flow rather than correlation to the neurotransmitter. As we know, physical activity is one of the best antidepressant, which could be used for general health, and also it will help and add a benefit to the migraine patients. So I don't think it's related to immediate effect related to the blood flow, because if the patient had an attack of migraine, I don't think the physical activity will help him. But if the patient achieve a healthy lifestyle, considering the regular physical activity, in such condition, I think it will help as a prophylactic treatment against migraine.
Okay, the next question is also to me. Dr. Harb, as we move towards an era of neurotechnology and brain-computer interface, how do you foresee future migraine treatment involving direct neural modulations, and what might be the implication by redefining the very nature of migraine as a disease? Very nice questions. Concerning in the future, I think migraine treatment using BCI or brain computer interface will play a certain role in prevention, even for acute treatment for patients suffering from migraine headache. Maybe I think in multiple level, first of all, we can use it as target brain stimulations. Even we can do something we call real-time brain monitoring or migraine monitoring. In this case, BCI could monitor the brain activity and predict when a migraine can come. In this case, we can use some devices to abort a migraine attacks. And even we can, with BCI, personalized a certain medical treatment for patient having migraine attacks. And maybe this will help us in multiple issues. First of all, we will have a fewer side effects, and we have better results, and even we can have a effective and potent medications. And let's take a simple example. Until 2018, we used traditional treatment without knowing the mechanism of action in treating or prevention migraine. But now, since 2018 until nowadays, we are using certain modality targeting the main neurotransmitter kind of better responsible for pathophysiology of migraine. Maybe in the next 2, 3, 4, 5 years, I don't know, we discover a new modulation or new neurotransmitter in the pathophysiology of migraine, and maybe we can find a cure concerning these diseases. The other is for Dr. Namarik, but she is not with us. Dr. Zidane, considering the increased recognition of neuroplasticity, how do you think the future treatment might not just manage migraine, but actively retain the brain to reduce the frequency and severity of attacks permanently, potentially rewiring the brain's pain response pathway? Always in it, she's asking a very nice questions.
Yeah. So thanks, Dr. Hind, for raising that issue, because the neuroplasticity, it's an era now in the neurology, you know, and if you can see in some patient like post-stroke, they have some kind of migraine-like headache or vascular kind of headache that we can see in post-stroke patient with vascular malformation. And some of these patients, even after treatment, they still suffer from such kind of vascular headache or migraine-like headache. And as we know, with the neuroplasticity and the neurogenesis and the ability of the brain to build up a new synaptogenesis and the new synapse, there will be some improvement over a time, even without specific medication. This is what we can see in our practice. I think these issues still need more research to clarify the exact neurotransmitter or the group of neurotransmitter that had been improved during the process of neuroplasticity or synaptogenesis.
Okay. The next question, what are the triggers for migraine? Concerning migraine, we have many triggers concerning migraine. We can start with skipping meals. For this, for every patient coming with migraine headache, we have to tailor a medical treatment for it. It will contain non-pharmacological approach and pharmacological approach. Concerning the non-pharmacological approach, we have to avoid all the triggers of the fact that the biggest factor concern with cause migraine attacks. We can, for every patient, should have a regular meals, breakfast, lunch, and dinner. Good hydration, especially living in Gulf or in EUE. We have a third, we have a good sleep pattern. We have to avoid excessive sleep or insomnia. We have to also to avoid certain food. For every patient, I ask him to note or to schedule or to write during the migraine or during the days that he have a migraine attacks, what are the food are taken. After 2-3 weeks, we can specify which medication maybe can trigger this migraine attacks. In this case, we have to reduce the intake of it, not to avoid it. In addition, we have to reduce the consumption of alcohol, even for concerning smoking, and even we have to ask for patient, and this is a very important issue concerning the female population, in case of increase of the frequency, even of the intensity of migraine attacks, we have to ask the $1 million question: if she is taking a new medications, and specifically OCP, because patient taking oral contraceptive pills will certainly trigger the frequency, even the intensity of migraine attacks. Dr. Tamer, what can you give in emergency treatment for acute migraine attack in a pregnant woman? I think you mentioned about acetaminophen.
Yeah. And in some difficult patient, we can consider Madol at the last trimester, the third trimester. Sometimes there are some trials using the occipital nerve block, but still it's not in the guidelines. Sometimes in severe patient or like intractable with status migrainosus, sometimes we use some of the low dose of bethidine that could be safe during pregnancy. I think this most of the option that we can use.
Okay, the next question, is migraine needs multidisciplinary consultation? Yes, because patient having high frequency episodic migraine headache, even patient having chronic migraine headache, or patient having medication overuse headache, in this case, this patient would certainly have a negative impact on his personal life, in his social life, and even his familiar life. In this case, the patient will have certainly anxiety and depression. Here comes a consultant concerning his case. We have to work between the neurologist, a psychiatrist, and even a psychologist. And maybe in addition to the traditional treatment for migraine, we can use, as I mentioned in my lecture, SSRI or SNRI to treat the comorbidity happening with migraine headache.
Dr. Harib, I have a question, if you allow me, for you and Dr. Tamer. So, do we
Yes.
have any concern regarding or any specific cardiovascular contraindication with the use of Vyepti?
Concerning Vyepti, it works on the GCRP. on the ligand itself, not causing any vasoconstriction or any harmful concerning the cardiovascular problem. In this case, for patient having high migraine, it is safe to give this kind of medications for patient having migraine without any risk factor concerning the cardiovascular problem.
So it's a better or preferable option than monoclonal antibody
Yes.
ligands in patient with cardiovascular
It
diseases.
is concerning biopsy, and we have triptans it are used certainly for abort a migraine attacks. But as you know, my patient giving or starting using triptan, we have high risk of side effect, or
Yes.
with the contraindication is they have a patient ischemic heart disease. In
Yeah.
this case, it's much better not to prescribe this kind of medication for certain populations. With biopsy, even with the other MAPs, there is no contraindication in using this new modality of treatment for prevention of migraine.
Thank you.
The next questions, kindly tell me which medicine, okay, it is done. Is ice play a role, Dr. Tamer?
Sorry, Doctor, how was the question?
Is
Ice.
ice play a role, ice?
So ice pack,
Ice pack.
ice packs. So if the
You know,
patient
there
put
are
ice,
there are some traditional ways. If we apply some ice cubes over the supraorbital nerve, it could reduce the muscle spasm of the occipitofrontalis muscle. But I don't think it's mentioned in the guidelines as a acute treatment, but it could be used as a part of traditional or alternative therapy, especially if it's applied over the supraorbital nerve, the occipital nerve. But I don't think there is like one study that had confirmed the use of that.
I'm not sure if there are studies, but doctor, I have seen patients in the clinic who actually having worsening of their migraine when they go to the mountains, to the eye, when they do ski. So people who lives in countries where there are snow and they go to the snow and to the mountain, they have worsening of migraine. But honestly, I have never checked if this is related. Probably the high altitude or going from low altitude to high altitude that have caused their the worsening of their migraine.
I know some patient who put ice on their head and they put their legs in a bucket with warm water.
Oh, really?
I think as Dr. Harp said, you know, there are many triggers. And usually when we make it simple for the patient, we usually told them that migraine hate the routine lifestyle. So first to identify the trigger, we need first to make our life in a routine way. Like, for example, during the weekend, if the migraine patient sleep 1 hour more, he will experience worsening of his headache. If he slept less, he will also have the same experience. So I think that change or the dramatic change from the daily lifestyle or the routine lifestyle itself could be a trigger.
And I have a final question before we close. We know a lot of patients, they take supplements for their migraine on top, of course, of their treatment. So what is the role of magnesium, vitamin B12? Just if you can elaborate on the use of such supplements for migraine management as add-on therapy, of course, on their migraine therapies.
You know, as per many vitamins, many electrolytes and minerals has been studied. As I remember, magnesium and riboflavin are the most commonly used supplement to help as monotherapy or add-on therapy. Sometimes we start with the magnesium salts alone in very low frequency episodic migraine if it's less than 4 attacks per month. Some people, they can get benefit from these natural salts and supplement. I think the most studied is magnesium and riboflavin.
Yes.
So with this, we conclude our webinar today, and I would like to thank our excellent moderator, Dr. Harib. So thank you for moderating and leading this webinar, and thank you for a very comprehensive presentation. Also, Dr. Tamer Zidan, who is joining us for the first time. So Dr. Harib صار من أهل البيت, يعني it's the
Thank
fourth
you.
or time that he joins us. So thank you, Dr. Tamer, for accepting our invitation and for a very, very really enriching presentation that I personally learned a lot from you today and from your talk. Thank you so much for being with us and looking forward for a future collaboration. Allow me to thank Lundbeck, our sponsor for tonight, for supporting this activity. Also, I would like to thank Dr. Namarik for her presentation, and also our numerous attendees, who were more than 700 attendees joined our webinar today. So thank you for all attendees who attended and who stayed with us until the end. And I also received some question regarding the availability of the recording of this webinar. Yes, all our webinars and educational activities are recorded, and you can visit our IVPN library if you would like to revisit the talk of our experts of tonight. And finally, this event is CME accredited, and you will receive your certificate of attendance by email within 1 week of today. Keep your eyes on our IVPN neuropsychiatry social media platform to know about all our events. Our next and third episode of this 360-degree multidisciplinary approach is scheduled in November. So stay tuned for more details. And until I see you, stay safe, everyone, and have a good night.
Thank you so much, Maya. Bye-bye.
Thank you so much, Maya.
Thank you.